maybe there's not a lot of people really trying to educate people about what it is and what it is not, right? And so there's a lot of false impressions of what it can do, and there's a lot of things that people just don't know what it can do.
Hey, welcome back to the show. Today, I have a colleague, a physical therapist colleague of mine, Dr. Ryan Martin. I've been following his post on LinkedIn for a while now, and I think I was connected with Dr. Colin Rigney for maybe years on LinkedIn before connecting with you, Ryan. What you guys are doing, we're going to talk about diagnostic ultrasound imaging, a fellowship as an option, as well as how you help other therapists get ready and prepared for the registered MSK exam if someone wanted to go down that route. The reason why I wanted to have Ryan on is because we've used diagnostic ultrasound in my mobile concierge practice. So we're going to cover things like that I've seen. I'm going to ask Ryan a bunch of questions. We're going to get into it. Not just the clinical side, but also like the marketing side, the word of mouth marketing that comes from it. It is an investment in terms of why you would add this into your clinic. I said to you, Ryan, in the pre-interview, like I can't even believe more therapists, especially the cash-based physical therapists and all these other folks charging out of pocket, have not used this. We are going to cover also billing, a price range, a dollar range in terms of payment reimbursement. We're going to get into all of that. First, Ryan, welcome on, man. What's going on?
Hey, thank you so much for having me on. Thank you.
You're welcome. So just give a brief background if folks don't know you already from LinkedIn or elsewhere, a little bit about yourself, what you guys do, what you and Colin are doing, as well as the practice that you guys work for and that you co-own, and then we'll kind of get into everything else.
Sure. Yeah. So, real brief background on myself is I am a physical therapist trained. So, my education is physical therapy. But for the longest time, even after graduation, I've really been a physician extender. So, I've worked in a lot of medical practices alongside medical physicians and practitioners. And so, yes, I do physical therapy, but what I really do is I work on MSK ultrasound, musculoskeletal ultrasound. And so, for the past decade or so, I've been in clinics, in and out of clinics, learning, and then I started getting into teaching. And so what you said with Colin Rigney, if anybody doesn't know Colin Rigney out there, he's a physical therapist as well, RMSK certified, such as myself. And we travel all over. We have our own website that we train. We have a fellowship or a residency that we train people in MSK ultrasound. And that's what we do is we try and spread the word of, good medical practice and using this tool, this modality in the most, reasonable way out there.
Awesome. Awesome. And like I said, in the pre-interview, I talked to Colin like maybe a year or two ago. We had a phone call because he and I had linked up or connected on LinkedIn. And then it wasn't maybe until a little more recently that you and I got connected. And then now you're posting, like more content than Colin, I think, which is awesome. And you're also kind of showing, now you're on Instagram, maybe some YouTube stuff. You doing YouTube as well?
I dabbled a little bit of YouTube. It really comes down to bandwidth.
Yeah.
What can I do right now? Yeah.
Well, because I watched a video of yours recently, maybe it was Instagram or LinkedIn, about you were in front of the whiteboard and you were doing the list of like the main landmarks that you would suggest that a therapist with examining the shoulder with diagnostic ultrasound. It was like a list of like here's how you would do it, or here's how like is a good idea to think about it if you hit these areas, short axis, long axis, in terms of like what angle the probe is located, and
Yeah.
all that. Kind of go through like a brief little approach. And I love that. That was just like one little
Yeah.
piece of content. And that's the type of stuff that I think we need to see more of in the profession. Like whether they go do a residency or fellowship with you or somewhere else, I really think diagnostic ultrasound should be in more practices. So we'll get into all of that.
Yeah. That was probably an Instagram that I probably took from a longer reel and then put on LinkedIn. I mean, I really like teaching. That's really what it comes down to. I mean, I think that's really my passion is teaching. And yeah, I'm old school. I still use a whiteboard. In fact, I have one right next to me. So if we ever need to teach anything, here you guys go. Here, I got my whiteboard. So
It's all filled up. It's all filled up with stuff on your whiteboard right now. Um,
oh yeah, I think that's my shopping list. Yeah. So
so, so with diagnostic ultrasound, I started using it in 2020, and one of my first. So first of all, I used there was this CEU company called Optics. I think that they no longer are operating anymore, but it was a physical therapist, I think, in Arkansas that was leading it. And anyway, I started to learn through them. And one of my first patients that I used diagnostic ultrasound, I got, and I don't get anything out of this. I got the Butterfly IQ. I'm not affiliated with them. I'm just mentioning, but there, like you said, there's also Clarius, which is similar, but like wireless. The Butterfly IQ that we use plugs into like an iPhone or an iPad or whatever, which is, I mean, it blows patients away. It really does impress a patient. That for at least for us, like going into a home or an apartment or something, or a hotel room for tourists, whatever it might be, people are always impressed that that's even, like the technology is there and that's even possible. But then also the word of mouth referrals from it. It used to be like, oh, myself, Dr. Dave, or some other therapist in my practice, like, oh, they're great, hands-on, or they're a healer, or they're passionate or professional, or they're excellent, or they got me results or whatever. That's how the word of mouth referrals used to be. And then it was someone reaching out and saying, James said that you have some, amazing portable imaging technology. And I was wondering if I could schedule an appointment for my shoulder or whatever like that. So the word of mouth referrals, the context or the verbiage around the word of mouth referrals now started to include a lot of the diagnostic ultrasound imaging, which in the whole plan of care was, a small window of time, 5, 10, 15 minutes or whatever in the first 1 hour visit. And then we have more follow-up visits that are an hour each time. So the word of mouth referrals, the context and the words used started to change and reflect more of the diagnostic ultrasound. I had that in my gut that that would start happening even before I bought the Butterfly. So I mentioned that because that's like the business case. That's like the use case in terms of like, yeah, it might take a couple $1,000 to learn. It might take a couple $1,000 to buy some equipment. But it wows patients. Everything else is the same also. And I don't want to go like on a long rant here, but like everything else in terms of like the movement screen, the evaluation, we're checking range of motion, strength, mobility, squat, lunge, ambulate with your shoes off, like everything else with the eval, at least for me, and I would love to hear your feedback. Everything else is the same. So like, what have you seen? What have you guys seen at Modern and in your practice with, why don't we start with like word of mouth referrals, or when someone sends their family member, neighbor, best friend, coworker, are they saying similar things?
Oh, yeah, absolutely. So, I mean, coming from, like I said, when I got out of school, I did a little bit of like regular training, physical therapy. I was in a standard outpatient practice. And the word of mouth was, exactly what you said. It was very standardized. And then when we started with practices in-house with MSK ultrasound, and you'd get repetitions and repetitions, and people would get better based on treatment algorithms and things like that. A month later, people would come in and they say exactly what you say. Like, hey, Roger had that ultrasound thingy. And I want to know about that. And we'll say, okay, well, let's talk about it. And then more people would flood in, and more people. And now people call specifically saying, hey, are you the ones that do MSK ultrasound? So like, as far as the general public is concerned, the awareness is growing dramatically because people reach out directly to us specific for MSK ultrasound.
Got it. Yeah. In terms of reactivations, or either reactivating the same patient that like now has, at least what this is my perception, is that it has kind of helped our ideal patient or client maybe views us in higher regard, or maybe we could go on LinkedIn and pontificate like practice at the top of your license, but like literally I think that is what we could be doing, or what we're doing by offering imaging. And like I said, there's no it's not like we're saying like, all right, this, we're, I don't know, affiliated with some orthos and we're trying to get people into surgery that don't need surgery or whatever. Like the beautiful thing is that there's no side effects. There's no radiation. There's no we can prevent things like extra surgeries or maybe injections or something at pain management that like don't really need to be done. And I feel like with what is it like the stat of like of all musculoskeletal pain or all I'm sorry of all low back pain in the United States, like only 10% of those folks get to physical therapy.
Oh,
And
it's terrible.
I mean, we're not going to change physician referral patterns. It's just at this point, it's just not really going to happen. But now things like what you're shining a light on, Instagram videos, things like that, that content, there's a ton of PTs now doing in clinic, exercises and drills and things with patients and clients with exercise. And that's great. And like we still do that, obviously. But more therapy practices offering diagnostic ultrasound, showing it, demonstrating it, showing it to the public that's something that we do, that physical therapists can do, that they can, like you said, call in, schedule an appointment, and in the evaluation, we're going to do all the normal stuff, the movement assessment, the subjective, the assessment, like hands-on, all that is the same. We're not trying to say anything different. And then maybe just adding like 5 or 10 minutes of diagnostic ultrasound to rule out some things. Like it just elevates the patient experience in a way that is not always possible without it.
I totally agree. And I think that's one of the big like things that you hear people talk about is, well, this is going to take away from your skill set or you're going to stop with your skill set. I think if anything, this is going to show holes in your clinical assessments, or it's going to augment, or, it's really going to take, you really have to have a critical thought process in your evaluation ahead of time before you even start thinking about using an MSK ultrasound, because you're not going to use it as the end all be all, right? It's exactly what you said. The evaluation itself should not change. But what it should do is what you said, is it points out whether or not it'll identify whether or not you were correct in your diagnosis, close to your diagnosis, or the severity of that diagnosis. Okay, and we make a treatment algorithm based on that severity. Is all right. And I think one thing to mention is our clinics are not strict physical therapy. Modern physical therapy sports medicine actually has physicians in-house. So what we do is we have both physical therapy and medical working in tandem with imaging to bridge that discussion base, right? But it's led by PTs, meaning that we get the first hand on them. So we discuss this with all, we run through the evaluations, we go through our clinical decision tree, and then from there we say, okay, are they a candidate for imaging, right? And if what kind of imaging? And in the state of Arizona, we now can order X-rays, and we will be discussing hopefully getting all imaging at some point. But or if we can do MSK ultrasound. So once we go through that algorithm, we've already used our clinical hat, for lack of a better word, to get us to that point, and now make that algorithmic change to like, all right, where do we go now? It's like that choose your own adventure book from when we were kids, right? So we're going to say, all right, where are we going now? Where we go now? Where we go now? Do they even need to see medical? Maybe, maybe not. Is it to the point where medical could augment what we're doing because we're an orthobiologic clinic, so we have options that maybe other places don't? And then if that's the case, how do we work that in tandem with our physical therapy? But then you also have to look at it and say, all right, from a functional assessment, something doesn't seem right. And then you do an ultrasound or whatever, and you find that this possible partial thickness tear or whatever is now full thickness with an avulsion or something that's a little bit scarier. All right, do not pass go, do not collect $200. Go straight to, we have ortho referrals. We understand that it's our due diligence, it's our duty to refer at certain points, but it's the imaging that helps us make that clinical rationale.
Right. Within your practice of I know you said you've kind of been like a like a physician extender, but like of the other therapists that are in the practice, are they pretty much all are MSK at this point?
And well, no. So when we go through our screening process to hire, we do have a very specific, and if you've met Colin, you'll know that he is very specific on his, like how he is and how he carries himself. He's very algorithmic and he's very structured. And we have very specific criteria if you meet that residency profile. So we have therapists that don't go through it, and maybe they don't want to, but we have therapists that really meet a specific criteria. If they meet that criteria, then they go through our program. And so we have a handful of RMSK certified therapists in our clinics right now that sit through all the different. We have 5 clinics right now, and each clinic has somebody in there that is either RMSK or working on RMSK with us in the background helping them.
Got it. I mean, it is a lot of, even if they do your type of like residency fellowship, does your staff therapist have to take some salary pay cut if they enter it, or do they pay some out of pocket, or the practice just pays for it?
So Colin and I have 2 entities, right? And so we have brick and mortar clinics that we're partners in, which is the Modern Physical Therapy Sports Medicine. And then Colin and I also own the education platform, which is both, virtual, digital, and the residency. So essentially, the Modern Physical Therapy will take that applicant or that therapist, and they'll sign a contract that they'll go through it for the next year to year and a half with, the intention to take the RMSK exam. That applicant then has a contract that they stay with the company for X amount of time. So they don't pay an additional fee or anything like that, but it's a contractual agreement that they will stay for X amount of time. And here's the thing is, if we did our job right, they want to stay, right? If we did our job right, they're not going to want to turn back around and just say, all right, here's your X amount of dollars back, right? So I think it's a win-win situation in that scenario.
Yeah. And I'm glad that you mentioned that, because if you're going to spend a lot of time and money on a therapist to kind of invest in them improving their skill set, then if without that contract, if they just then leave, I mean, they move to another state, they go to another practice, whatever, that investment that they just, added to their brain, it is out the door. Right. So then that makes, and that type of agreement is common even in terms of like some bonuses, like sign-on bonuses sometimes, or like a sign-on bonus that's maybe 10, 20K or something, but it's like you have to stay for a year or 2 or 3 or whatever. Similar with like the student loan repayment, right? Like they'll pay for X amount, but you got to stay for 1, 2, 3, whatever years, depending on the agreement, right?
Yeah, and that's how we kind of structured it. And I mean, it's worked very well up to this point. Yeah, for sure.
Got it. So let me go back to the word of mouth reviews. So like with you, Colin, some of your other therapists that have this skill set, are there any like examples of patients scheduling evaluation? Like maybe it's a previous patient, they're coming back, or they're referring someone to Modern to specifically go to Colin or some other physical therapist in the practice, that usually, if you guys didn't have the imaging skill set, that person would be looking for an ortho, they would be going somewhere else. Like, do you have any examples of that?
Yeah, I mean, it happens all the time, especially with pre-existing patients that referred somebody, or they'll send to us, and they'll either say like, maybe they did already have like their primary care doctor say, maybe we should go to an orthopedic referral, and they'll call us and they'll say, well, hey, I know you guys do the AMSKU ultrasound, can we check this out? And so that's a great referral base that they come in, we'll screen them. And then we, at the end of the day, we might say, you know what, maybe you should go to ortho. Or a lot of the times it's like, hey, this doesn't necessarily, like, let's see how we can work on this conservatively and see what we can do with that. And it usually ends up being a great scenario.
And it certainly builds trust in the therapeutic alliance.
Oh. The trust in it is massive. And again, not to go into too much depth or other tangents, is I just had I did a lecture for our residents just the other day about how we patients, right? And how do we implement this type of modality without scaring them off or getting into too much, is how do we build that know, like, and trust, starting with that know, getting to know who you are, building that like, explaining the technical services, and the trust. I was all right. Okay, now they trust you and they bought into what you're talking about. Not like a business per se, but they want to be a part of what you're doing. And at that point, they'll tell their mom, they'll tell their best friend, they'll tell whoever, and it's just a cyclical, system at that point to where, this is part of their family now. This is part of their network. They know about it, and so is their network. So.
Right. That makes sense. let's get into like billing, cost or not cost, billing, payment, that type of stuff. Now, initially when I started doing it, I was, I'm still not RMSK, certified. I didn't go through the formal course, which real quick, let me stop there. That's optional, or is that mandatory? Like, have I been doing it wrong by doing some imaging, or is it optional?
You're doing it really wrong. No, no. It really comes down to no. You're fine. At this point in time, legal guidelines and standards do not say that you have to have RMSK. Now, does that mean that you shouldn't pursue it? Okay, well, this gets kind of into the weeds, because do I know people who are non-RMSK certified that are phenomenal scanners? Absolutely. There's no indication from reimbursement or whatever say that you have to have that at this point in time. Now, does that mean that might change in the future? I can't, I don't sit on that board to find out like what's going to happen in the future. But no, you can scan without it. But in the state of Arizona, when I contacted, the PTA here, the Physical Therapy Association here, and they said, well, you really need to just know what you're doing. So if you ever get called to a court of law, right, you need to know that there's some sort of training involved and you understand what it is, right? You take that at your own risk, of course, so I don't tell anybody, oh, go scan without RMSK. But I think ultimately, in my personal opinion, that should be the goal. It's the highest level. It's not necessarily the easiest level to attain, but it's definitely the highest level to attain. And that title carries weight in not just, physical therapy realm, but physician status. I mean, it was an exam designed by physicians for physicians, right? So it's not the easiest exam, but even when physicians carry the title RMSK, because if you have RMSK and your MD partner down the road has RMSK, guess what? It's the same certification. So I think it's something that you should strive for, but that's a personal bias. You don't legally at this point in time need it. You don't technically need it at this point in time. Hopefully that answered it without going too far.
For sure. So, and then in terms of the payment, so I get the question often. Initially, when I was doing it, first of all, I was telling my buddies, like my baseball buddies and all that, like I was using it. I was saying to them, like, hey, I'm kind of like learning with this remote company. So like, can I scan your knee? Can I scan your shoulder? Some of the guys have aches and pains, whatever. So they were happy to do it. And it was like, initially it was no fee. So it was just like, I wasn't billing insurance. I wasn't even collecting payment from them. I wanted to get reps, right? I wanted to get repetitions and practice and all that. Then when we started using it with actual like patients and clients, I didn't like bill insurance. Like I want to get it to that there are two codes that you're going to mention. Haven't billed out of network insurance, and then for the private pay folks that are paying out of pocket, I just included it into like our rate. And so if they're paying like a full, like we do 60-minute home visits, on demand visits, and it was just like part of the evaluation. So for us, I mean, I know there's some practices across the country, even if they're cash based, that they'll charge more for the evaluation and then less for follow-up visits. For us, we just do the same dollar amount for all the visits. And if that eval has diagnostic ultrasound in it, it's just the same dollar amount, the same rate. Patients also like that too. It's like a little surprise and added bonus that they like. It's not an upcharge or an add-on, but it totally could be.
Yeah, it totally could be. And I see it vary across the board on how people utilize it. A lot of cash pay practices love this as an add-on. It adds such a huge value from a patient care perspective. Obviously, it gives a lot more trust into the evaluation with that patient buy-in, right? But yeah, as far as like the billing codes and stuff like that, if you want to talk about the codes and that kind of stuff, yeah, we can dive into that for sure.
Yeah, I think in the pre-interview you mentioned there's two different codes. What are those again?
So there's two specific codes for diagnostic. Now there's interventional codes as well, but PTs themselves won't go into those. And I think I should just disclose real quickly is I don't just educate PTs. Our residency is PTs, but I train, medical doctors, DOs, PAs. I teach the medical, healthcare, alliance, essentially like, anybody that can sit for the exams and that can do these, that's what I teach it for. So we also have to know some of the interventional codes and some of the other stuff out there. But if we're sticking to, like if you're a physical therapist and you just want to know the codes that are reimbursable for MSK ultrasound. So there's 76881, which is what they call a complete code. And I'll go into that in a second. And then 76882, which is called a limited code. So what do those really mean? It breaks down to this. A complete code, by the letter of the governance of how it's written, is more than one structure, so plural structure in more than one plane. Okay? So when they say more than one plane, you look at things in two different planes, axial, sagittal, parasagittal, whatever it is. You look at two different structures, and technically that's a complete scan, right? Now, our algorithms are not generally just two structures, right? I didn't just look at a supraspinatus and a bicep. I usually looked at a lot of other things. But if you look at two structures, by the way that it's written, you can do a complete. Whereas on the flip side of that is a limited scan is that you looked at one structure in two planes. Okay, you looked at one structure. So if I just wanted to look at a patellar tendon and just a patellar tendon, now why you'd want to do that, I don't know. But if you wanted to look at a patellar tendon and just a patellar tendon, you looked at it in one plane, two plane, and I'm done, that's a limited code. It makes more sense post-operatively if something happened, right? So if somebody came in that was, I don't know, a supraspinatus repair, and I talked about this on one of my posts. If somebody came in as a post-op, they're a couple weeks out and they fell, they bumped it, they did something, they thought they tore it. Sometimes we'll actually have ortho send to us to where they say, all right, hey, we know the MRI is going to look like just hodgepodge, right? MRIs never look great post-op, right? And you can't really make sense of what's going on in there. Whereas
there's swelling and other stuff in the way.
There's so much other things going on. Whereas an MSK with an ultrasound, the resolution is very defined. And you can see those suture lines, you can see the anchors, and you can see the tissue in between to see if there's been any disruption of it. You can also test it dynamically. That is one of the huge benefits that MRI, X-ray, or any of the other modalities out there can't generally do anything dynamic. Well, if you have what looks to be a stable supraspinatus statically, and then you go to move it and you see it separate, you're not going to catch that necessarily in NMR. And again, if it's post-op, it looks like just a potpourri basket, right? And so what we can offer in a limited, and then we're going back to the billing, of course, is what we could offer is just look at that supraspinatus, look at those anchor sites, and check it dynamic really quick in two planes. Because again, remembering in radiology, one view is no view. So you look at it in multiple views, and you can determine, all right, those anchors are popped, that suture is torn, that tendon is now retracted, or it's stable. Get the phone call to the doc, build that rapport. The patient loves you, right? Or they don't because you found out something terrible. But either way, they got the information that they needed within a couple minutes.
Awesome.
And again, that would be the case to where I would use a limited versus a complete billing code. Is I looked at one thing only. So the first code is when you're checking patellar tendon, quad tendon, the medial and lateral joint lines, like other structures more than one. Yeah, anything plural, realistically. And when you look at a structure, and this is what I teach to our residents, this is what I teach when I lecture and I travel, is when you're looking in there, rarely are you ever looking at a single structure. I mean, if you think about differential diagnoses, if you think about the way the anatomy is, everything overlies each other, right? And so you have to look at all these different structures anyway. You have to understand what you're looking at, why you're looking at it. But if you're looking at a singular structure, to me, that's not doing your job.
Yeah, it makes a lot of sense. How about the range of reimbursable payment that you've seen for these scans, for those two billable codes?
Right. I mean, you can look up Medicare reimbursements on 76881 and 2, and they'll vary a little bit. But I mean, you're looking at anywhere from $50 to $100, somewhere around there. Now, again, rates change, insurances are all different, but I mean, that's kind of your general window of what is reimbursable without giving away too much, like, all right, this is what we get paid. That's kind of a window that I've seen.
And those two codes, those are CPT codes, right? Treatment codes?
Those are CPTs. Yeah, CPT codes.
And are they untimed? So like if you got efficient over time with scanning, you could make that $50 to $100 reimbursement, even if whether you did it in 5 minutes or it took you 15 or 20 minutes.
Yeah, there's no time base on it.
Got it. So that's another benefit for therapy practices in terms of, as opposed to the 8-minute rule with, manual therapy and Therax and all that, and all those units are timed.
Correct. Yeah. Those are untimed codes. And so they are what they are for whatever you take. A majority of scans, as you get proficient, they don't take that long, and the setup with that is real easy. As you're talking to your patient, I think you were doing this with your patients as well, is as you're doing your examination, you're doing the ultrasound, you're getting the information, you're doing all that kind of stuff in tandem, right? Like you can be doing all of that. You're getting your mind wrapped around to like, all right, this is what my clinical thought processes for the diagnosis. And now you're scanning and you're still talking to them. You're still collecting data. It doesn't have to, it can be very, smooth transition into all of it. And then, you have plenty of time to do other things with, the rest of your time of your session.
Yeah. And another thing, going back to like the word of mouth stuff, or just patients, what they're saying, I haven't really marketed it too heavily, but there are some images and pictures on my website. And since I had been doing it, new prospective patients that call in, since adding it to the website, will mention it. They'll ask about it up front. So meaning you just said like, oh, you have it with you. And like, depending on how the evaluation, the conversation, the subjective is going, maybe you grab it, maybe you use it, whatever, right? Like assuming the practice style and all that. But for us, it's like, we know up front, like we have to know obviously the patient, like where we're going, where they live, like all that. So we're getting like the condition, the situation, diagnosis, where they were referred by someone or found us on Google or whatever. But more and more people have been asking about it by name. Like, oh, do you do that? Do you do the imaging in this area of the city? Or I have this issue. Like, do you do the diagnostic imaging for this, like for low back or whatever? Or is it more like, they don't say like, is it for extremities only, but like right. They'll ask about it. And that was another thing, like on the front end, which is catching their eye, that they, and I like the word, like, this is like, the word remarkable. I'm not saying we're remarkable. I'm just saying the word remarkable, meaning something that caused someone to make a remark about it. And so they were asking about it on the front end, which we go back to, you said no, like, and trust and like building, I said the patient, like patient experience and therapeutic alliance. People seeing those things, it's like, oh, this, like, because they might call 3-5 other different places, and there's no one in New York City that's doing home visits that offers diagnostic ultrasound imaging. So they come across our website. It now looks a little remarkable, or they make a remark about it, and that also is a differentiator, can set you apart versus your competition.
Huge. Yeah, absolutely. And again, we're hoping that, this becomes more commonplace, but, for a lot of the pioneers out there doing this kind of stuff, this is a massive opportunity, to have something, especially a skill set and the ability to do things that other practitioners cannot.
So 100% agree. How about the storing of the images or videos? So like, I don't know if you know too much about, I'm sure you know about the Butterfly, but like with the app, you can take still images, you can save video, like you can record video. I love how you mentioned, I forgot about that. I love how you mentioned dynamic imaging, right? So you could, put it on someone's, a patient's anterior shoulder and view their supraspinatus as they're going into abduction and movements of their shoulder, which you can't do with X-ray, you can't do with MRI. Patients love that. I forgot to mention that, but you brought up like the dynamic movement. So,
but the one thing that is really interesting about that is when your patients do call you and ask you about this type of imaging, how many people are taking an X-ray, putting it in their pocket and taking it to a patient's, residence? How many people are taking an MRI? There is mobile MRIs. Don't get me wrong. There's like very interesting things out there, but the availability is pretty. It's not going to happen. Whereas some of these ultrasound machines, they attach to a cell phone, right? Or they attach to a tablet. It's these things. It's like you said, your patients, like, you have to know ahead of time. But do you? I mean, realistically, how much real estate does that machine take in your vehicle, right? So for you, you could have it on the go at any point in time and you're ready to go. So I think that's one of the biggest benefits right there is, especially if you're traveling and you're doing concierge, you're doing things like that. Or if you have multiple clinic rooms where you have to bounce from, hey, I'm in room 1, room 3, room 5. This thing travels so quick and easy that that's another game changer that people don't understand.
Right on. So what I was saying before about saving and storing of the imaging,
yes,
is that something that is required in the imaging world? Does it need to get into the medical record? And obviously, you'll have to, anyone watching or listening, you have to check with your own, attorney for any of this thing around compliance and HIPAA and PHI and all that. So definitely speak to Daniel Hirsch, someone else who I had on the show about risk and compliance. But from what you see, what do you guys see with storing of the images or videos?
yes.
Are they stored in the software of the diagnostic ultrasound imaging company? Do they have to be transitioned into the medical record?
Right. Okay. So without getting into legalities, right?
Right. We're not lawyers. We're therapists.
We're not lawyers. We're physical therapists. But anecdotally, no. No. Here's the thing: is most of these machines store them in a drive of some sort, right? Then you have to start to think to yourself, all right, is that a protected drive? All that. But when we're in our clinic, and I'll just speak from our clinic perspective, all the images go onto a machine, right? And then they're transferred to a stable, a solid state terabyte, hard drive. And then they're stored in a locked container that is HIPAA compliant, right? And then those images are then taken off the machine, away from the machine. And so those are stored in a safe place. And then we keep those records for, I think, up to 7 or 10 years. Again, I don't remember. But yes, you have to have, because if you ever get called into a court of law on a scan that you did, and you cannot demonstrate the images that you are basing your diagnostics on, well, then you're going to be in trouble, right? In theory, right? And so you need to have one image for whatever you talked about in your documentation. So if I talk about supraspinatus, I better have an image of a supraspinatus. Or if I have, if I talk about the Achilles, there better be an image of the Achilles. Now, is there currently anything stated that I'm aware of that says how many you have to have? I don't have that information. But for us, one view two views for each structure that you talk about. So that you're talking about two different planes. So what you say is what you say. So if you say there's a tear, you better have multiple views of it to prove it, or dynamic availability to discuss that. That's how we do it. And then documentation, yes, that all goes. Now, the images themselves, we do not store in the EMR. Okay, those don't get stored in the EMR, but they can be pulled from those terabyte, from those hard drives at any point in time that the patient signs a release or gets if they want those images and they want to take them to so-and-so, or for whatever reason they want them. They want to print them and hang them on their refrigerator. Whatever they want to do. We have the availability to get them those images. And then the documentation does go into the EMR under their record.
The documentation, meaning the typed out document, the note.
The note. So again, when you do a scan, you have to have an accompanying, documentation to state what you did, why you did, all that kind of stuff. And that's interesting that you say that. Is we're talking to our residents right now about proper documentation within our company guidelines on how we have it structured. And it's very, very similar to how a radiology report would have it, so you have the date, the patient's information, all that kind of stuff. And then it goes into why are they here? What body part is it? Left, right, all that kind of stuff. Who did the scanning? And then you have your imaging findings, which is basically what you see on the screen. And then you have your impressions on the bottom, right? So very similar to how you would read an x-ray or whatever, like that. That's how we write them out. And then we use those, and we talk about them between our clinic to make sure that we're doing them in a very consistent fashion.
Got it. All right. So we talked about a lot. We talked about the word of mouth marketing, which folks, again, I do not benefit if you go and buy any type of unit. I'm kind of out there a little bit mentioning, and I have another video that I did with, I think, did I do it solo or with Jimmy McKay about, I think I did on Jimmy McKay's PT Pinecast, and then we're going to reshare it on my show about diagnostic ultrasound, similar to this, of how I've used it and my impressions of it and all that. why I can't believe that it's not more common. Like, is it just because it's a little more medical than what we're used to? It's something that the profession hasn't really done, and so therefore, um, we're the PT profession is like a little bit of a laggard with this. I mean, there's PTs that now can do this. There's chiropractors that are doing diagnostic ultrasound. Obviously, physicians have been doing it for years. What are your thoughts around physical therapy and or like the state of physical therapy in relation to MSK ultrasound?
Well, it's just like anything. It comes down to how has it been marketed within our own, group, right? And that's why I'm trying my hardest with the social media is to get people educated on what it is, why we do it, and the usefulness within clinical practice. Maybe because there hasn't been a lot of people doing what I'm doing. You know what I mean? Maybe there's not a lot of people really trying to educate people about what it is and what it is not, right? And so there's a lot of false impressions of what it can do, and there's a lot of things that people just don't know what it can do, that people don't know what they don't know. And I think, to your point, I think is just nobody's been out there pushing it, right? Nobody's out there making the leaps and bounds and strides to make sure that our community actually understands what we have at our availability. Like what we have at our disposal is something so powerful, and it has to be used the right way. So, and again, these are opinions, and I stand strong on them, but I really don't think that there's a lot of people out there that are pushing it really, really hard, and the ones that are, they're starting to gain momentum.
Right. Right. All right. So we talked about like the education and the training part of it. We talked about marketing it. There was another marketing idea I wanted to bring out. The word of mouth marketing. We talked about the CPT codes, the billing, the range of reimbursements that practices have seen out there. We've talked about compliance, risk and compliance with storing the imaging, the note. I love how you broke down the note. Obviously, that's part of the medical record. The images, you'll have to figure that out on site, but like separately and not in the medical record, unless it's called or, some medical release.
Well, I mean, some people might, right? Yeah.
So one thing, I can't recall the practice, and it might have been on like Instagram or something, but I have seen at least one or more practices that are offering, and I can't recall the name, but that are doing diagnostic ultrasound where they have like a scan night or something where it's like, from 6 to 8 p.m. it's, stop by and we'll scan whatever. And I was like, that's kind of genius in terms of marketing. Now, they literally are saying like, come, stop by for a free scan if you have any aches or pains or whatever. It seems like that, like they would actually be doing the scanning and then I guess not even billing their insurance. They're saying it's like a free scan or whatever. Have you seen any of that? Does that sound?
We've done, yeah.
Bad idea.
No, we've done marketing things like that. I mean, we have a whole team of people that make sure like the compliance is there and all that kind of stuff. But we've done, things to where we've hosted certain events to where people can get, it's like those quick little like discussions like, all right, are you a candidate for physical therapy? And this falls into that kind of those type of marketing type of deployments, right? So yeah, I've seen those, absolutely.
Got it. Right there, right? So what you just said of someone stops in, let's say, so I don't have a brick and mortar because we're mobile concierge visits, but we're looking to partner and acquire practices. So if a practice owner has the brick and mortar office, you do a scan night, you say it, it's literally free, right? So like 1 hour, 2 hours, whatever, first come, first serve, sign a check-in list or whatever. And you get a free scan and there's no cost. Then what you just said is genius, which is, well, let's see if you're a candidate for physical therapy. Then assuming you have someone who's trained and experienced in MSK diagnostic ultrasound, and you show them here's structures, here's what this is, here's what this is, this looks good, this looks clean, this looks everything, they thought it was a tear, they thought they had a lot of wear and tear in their knee or shoulder or whatever, and then you're demonstrating like here's the smooth outline, like here's the supraspinatus, here's maybe you pop open Google Images, like here's an example of like a partial thickness tear of a supraspinatus, and you see how yours is like nice and black and dark, and and there's, fine lines along the edges. So here's what normal looks like, or here's what, maybe you have some impingement or some inflammation or something, but structurally you look pretty good. Where do you think that person's going to go for physical therapy? They're already in your office. They're already looking at you as the local expert or your staff physical therapist who just trained under you guys or whoever else. They're looking at that therapist as the local expert in that condition. Hey, like, yeah, we can, here's our rates, or yes, here's some insurances that we take or don't take or whatever. But yeah, like, of course that person's going to go to you guys for therapy.
Yep. You built that trust. Absolutely. So yeah, I mean, you hit the nail on the head on that one. Yeah. And again, I've seen marketing, things like that before. And, you're just very specific on language, is making sure that you're not giving them, like you're not trying to diagnose, you're trying to lead them to an understanding that, hey, maybe you'd be a good candidate to, see what we can offer, and you're in pain. Okay, well, we understand, we can kind of see some things in here that could generate some pain. Do you want to, come visit? You know what I mean? Like it's a good opportunity, to sign people up.
So in your, let's say you had a direct access patient with like that shoulder example, you do the eval through insurance or private pay or whatever. And then in your note, you're not writing an anatomical diagnosis. Like if you see like a partial thickness tear of a supraspinatus, you're not writing that, or you're not diagnosing that.
So this is where we get into a lot of the semantics of, documentation and language. So when you look at structures, you write the structures as you see them, right? You're not going to give it a ICD code, per se, saying it is a, full, like you're not going to say something along like ICD. You're not diagnosing it ICD-10. No, you're labeling it as you see structurally, right? When we send it off to our medical providers, they're going to look at that. They're going to oversee our notes. We're going to have a discussion. They can write, that ICD-10, right? Because they're medical, but we have them in house. But as a PT, you have to be careful about language, right? And so this is where Colin and I have, back and forth about like, and you always have to check with, your practice guidelines. You have to check with, like, where do you stand on language? And this gets heated. This discussion, I mean, you want to talk about.
Colin gets heated on this because I reached out to you guys. I wanted to have you maybe both on, and we're all busy, and maybe I'll have him come on another time, or you.
Oh no, what you need to do is have us both on and just be ready, because there's fireworks.
So he gets heated, meaning he wants to use the anatomical diagnosis, or what?
Language wise, he and I may differ a little bit on, all right, what can you say? What should you not say? Because I mean, again, we have defined criteria of what, physical therapists can say in our notes, right? Can you legally, or by the scope of your practice, put an ICD-10 for a medical diagnosis of like a supraspinatus tear, right? Like that's where the debate comes down to is, well, by law, go check, right? For me, you're putting down all the anatomic structures that you're seeing the defects in them, you're seeing what's going on, and you're showing how that relates to their function, right? And when I put my, codes in there, it's going to be with the codes that we typically use, right? It's going to be with, the shoulder pain, the, all the things that we have in there. And then I have my ultrasound note in there on top of it, and it explains everything anatomically that's going on and how it relates to those problems, right? But at no point did I say ICD-10, shoulder, I didn't write that, when in our EMR, it has a little box that says, what's your diagnosis? And I stick to the lanes that we have in PT. And there are some people out there, and I won't call out names, that say, no, you have to put, because you're RMSK certified, you can put XYZ. And I'm like, this is where it gets kind of like a little gray, right? And so that's where you want to, because I know your fit post that went out there, and yes, I'm going to bring it up. Your fit post out there, it fired some people up, and hey, I am all about the controversy, as long as it's healthy, debate, and it doesn't get into more trolling. I'm into the healthy debate.
Question, agree or disagree?
I know. And well, I mean, of course, you had to put a picture of, those smoking guns on there, right? But the thing is like, this topic, similar to should you be fit and charge $400 versus, okay, legally, non-legally, gray area, non-gray area, what can you say in a PT note for diagnosis? It goes back and forth. And again, I stay on the very conservative side, very, very conservative side. And I teach on the very, very conservative side, staying to the lane, and then understanding that when you write your documentation, you write what you see, right? You write exactly what you see, but you're not necessarily using the medical diagnosis codes to, at the end of the day.
So for example, you'll use the ICD-10 code of like left shoulder pain, whatever that ICD-10 code is,
Mm-hmm.
as opposed to left supraspinatus, whatever, impingement or partial thickness tear or whatever.
Right. Initial encounter.
Right. Which could
right.
Encounters are for physicians, right?
Yeah. Well, yeah. So this could go in so many directions on, like, this could be a talk all on its own, and you could get people from a few different camps, and you could just watch the fireworks here, because I've sat in on many of these discussions, and again, it just being a fly on the wall, just trying to learn as much as you can and stay within your scope of practice is the biggest thing. And when in doubt, call your board, right? When in doubt, find out, call your local advocates, learn what you can and can't do, right? I mean, like you said before, we're not lawyers, right? We're not trying to give legal advice on what you should and shouldn't say. Do your due diligence, right? I just know for me, I stay pretty specific to the physical therapy standards for my language.
Got it. So Dr. Colin Rigney will document the initial encounter, like the anatomical.
You should have him on your show.
So how about this? Let's say if you and him both evaluated two different shoulders, you used the left shoulder pain, but the diagnostic ultrasound CPT code at the eval, and then he evaluated another individual, similar diagnosis. He used maybe a different ICD-10 code, but the same diagnostic ultrasound CPT code. Have you guys seen that they're both going to get reimbursed the same?
Well, again, I don't want to get into weeds. I don't want to speak for Colin, because I really think that he should be on the show, and I think it would be fun. But at the end of the day, I don't think any of our therapists put in the ICD-10 codes that are out of medical, but his language might be a little bit different in notes. I guess that should be a better terminology, like a better way to explain it. So like at the end of the day, our ICD-10s will still follow suit for, for the guidelines of physical therapy. And then of course the, reimbursement for, the diagnostic codes. So no, those won't be any different. But maybe in the write-up might be a little bit different.
Got it. Do you and Colin also do like expert witness type stuff?
We haven't. I haven't.
I'm just trying to think of other topics that I could bring up on that call with you and him that would kind of rile you both up.
Oh, yeah, trust me. I mean, we've been like best friends. Like, we've known each other for so long. It's like one of those things that if you get us going, it'll be fun.
And he was on the Montel Williams show at some point.
Yeah, we both were.
You both were.
Yeah, we both were. Yeah. So our practice, they reached out to us, and because for whatever reason they heard about what we were doing as far as like the hybrid of medical PT and imaging as a bridge, they really liked that idea. So we were lucky enough to be showcased on the Montel Williams Balancing Act.
Wow. Okay. And how much do you guys have to pay for that? Or was it free?
It wasn't free.
Oh, it wasn't free?
No.
Oh, okay. So
you have to, well, again, not getting too far in the weeds, but you have to pay for the film production crew to come to your location.
Got it. I actually thought it was going to be something they reached out to, and I was going to say, well, it's because of the imaging, right? Because, okay.
Yeah.
All right. So
no, they heard about us. Yeah. They heard about us.
It's still a marketing thing, though, a marketing investment.
Yeah, it was a marketing investment for sure. And it's funny is we are in the Phoenix area, and we get phone calls from all over the country now.
There you go. Have you guys have you had patients or clients like drive real far or fly in because of any of what you're doing?
Not yet. Not yet. Just our residents.
Got it. Got it. All right. Well, Ryan, perfect place to pause. We covered a ton of ground in a fairly short period of time. This was great. How about either your LinkedIn email address? What's a good place for the audience to reach out to you if they want to learn about the training, the residency and fellowship, or just learn more about your practice?
Sure. Well, I mean, I think the biggest thing is I want more physical therapists understanding about MSK ultrasound. There's a lot of resources out there, and I'm not opposed to pointing people to any of those resources, to be honest. Our resource happens to be amsku.com. That's us. And then of course you can find me on LinkedIn. That's my big, that's where I do most of my posts and education, outside of my, business is on LinkedIn, and that's just Ryan Martin PT or something like that. I don't know. But for the biggest thing is just like, reach out to me if you have any questions, comments, or concerns about MSK ultrasound. Yeah. And so I just wanted to let you know, I don't know if you can hear the rain, sunny Arizona, and it is a massive rainstorm. Anybody that's been following me on social media knows that I've lost my studio space on multiple occasions lately. I started in my guest house, and then we put a travel nurse into the guest house. Then I went into my garage. I got kicked out of my garage because my wife wanted her parking space back. So I'm just going to kind of show everybody this. This is my RV.
I mean, you look like a legit studio before you peel back the curtains there. It worked.
So now I'm doing everything out of an RV until further notice, until my wife wants to go on a vacation. So thanks for bearing with me in the rainy RV in sunny Arizona, but not so sunny.
Yeah, no, I didn't hear any of the rain at all, but
good. That's perfect. Well, thank you for having me. I appreciate you.
Of course. Thank you.
Hey, it's Dave Kittle. Are you a healthcare business owner or physical therapy practice owner who is looking to figure out your succession plan or exit strategy? We might be able to help. And in fact, we may be interested in acquiring your practice. If you're interested, you can reach out to me. Shoot me an email at dave@conciergepainrelief.com. That's DAVE at CONCIERGE, painrelief.com. Or you can call me at any time, 646-781-8884.